Our next speaker is Michael Kenney, who is going to give us an anthropological view. Mr. Kenney.
My title is something of a misnomer. I wouldn't exactly call it an anthropological view. I'd call it my view, which is based, of course, on my personal experience with a variety of issues pertaining to comparative issues in psychopathology and also in the cultural history of Western psychiatry per se, particularly North American psychiatry, out of which, for example, the concept of multiple personality disorder or dissociative identity disorder emerged. One of the things that I've noted in this debate, particularly when it's aimed at experimental psychologists, usually by practicing clinicians debating the reality of the false memory syndrome, is that this is a laboratory type of study which doesn't mirror the real world context of actual therapy. I'm somewhat sympathetic to that view, though I think it can be confuted. Anthropologists, on the other hand, have a slightly different problem. They see settings that are all too naturalistic and quite uncontrolled. But on the other hand, this brings certain advantages in that one can begin to see the complexities of the way in which knowledge is generated in real-world situations, including knowledge of self. That basically is my topic. It always has been. The relation between theoretical knowledge on the one side and subjective self-existential phenomenological knowledge on the other side. There are always interesting feedbacks between cultural assumptions and self-apprehension, and I think we're looking at some of these feedbacks in the current debate over the reality of false memory syndrome and indeed the reality of certain psychiatric syndromes currently in the DSM system associated with it. Let me give you one example that indicates the type of take that I would bring to this sort of subject. It's not, in this case, anthropological, though it's very close to it. I've been interested in 19th century spiritualism, the idea that the dead can return through spirit mediums and speak to the living about the conditions in the next world. Of course, this was a very tendentious matter in the 19th century, pertaining to the reality of the spirits and the powers of the spirit mediums to go into trance and serve as conduits for information coming to us from the next world. Marvelous studies were done at that time to try to establish just what this phenomenon was, and the idea of the unconscious, as we now understand it, arose out of some of these studies. Very much the same kinds of people were involved with the study of spirit mediums as were involved with the development of the idea of the unconscious, to name a few: Jung, Freud, Morton Prince, William James. So in these studies, leaving aside the metaphysical questions about the reality of the spirits, there was marvelous social psychological research done on how the reality of the spirit world is given credence in spiritualistic seances. That is to say, how has the spirit managed to convince people, often its own relatives amongst the living, that it is indeed real? We have a spirit medium who's in trance. We have a sitter who is trying to contact the next world. How does a sitter come to be convinced that the entity supposedly speaking through the spirit medium is in fact real? And it turns out there's a long process of development that emerges out of the seance transcripts, many of which were recorded by the British and American Societies for Psychical Research. These are the ancestors of our modern-day parapsychologists, which revealed that the process is a very complex social process through which the medium learns what is expected of him or her and eventually begins delivering with greater and greater credibility messages that really do seem to be from the beyond, from that particular dead person. So given that kind of information emanating from the 19th century and given the comparative approach of anthropology, we're able to put together a kind of social psychology of natural settings, a bit I think like what Professor Offshee was talking about, and see how this actually operates under what might be called real-world conditions. That's one of my topics now, but there is another. It has to do with an idea that is in such common circulation that I believe that people commonly forget where it came from, or in fact don't even know. It's the idea of paradigm. I just happened to pick up something outside that reflects this mode of thinking about how knowledge is structured. It's called the World Paradigm Questionnaire. You can pick it up on a table out here. Now, it seems to pertain to a total worldview. It's a kind of psychological test of sorts in which you're supposed to select from a variety of elements. And the way in which you distribute your selection indicates your world paradigm, the fundamental structure of your perception, apprehension of the world. It is this term paradigm that's going to concern me first. And again, this comes from my own experience, not so much from anthropology in general, but from my experience with the entire false or recovered memory debate. Now, at this point, I proceed somewhat more formally. The recovered memory debate involves the problem of just who has the right to define what is counted as a psychiatric disorder. On one level, the answer is fairly obvious, at least so far as North America is concerned. The American Psychiatric Association, through its specialist committee structure and review process, has that right, and the Diagnostic and Statistical Manual is the codified result. Critics of the concept of false memory syndrome therefore often focus on the illegitimacy of the civilian advocacy group promoting it, the FMSF. From this perspective, syndromes do not exist until the relevant experts decide that they do. And this is quite correct insofar as such experts are in fact the gatekeepers for what is to be admitted as official wisdom. Politics and science are certainly uneasy bedfellows, and yet in our times we have become very aware that the creation of knowledge, any kind of knowledge, is a social process and inevitably some sort of political process as well. A process of interpretation, confrontation, and negotiation. I have been involved with the prehistory of the recovered memory controversy, followed it since its inception, and been a minor player in the debate myself. As an anthropologist and sometime cultural historian of the concept of multiple personality disorder, this affair has been an education in the politics of knowledge. I first offer my observations on that subject and then move on to outline a comparative approach to the interpretation of misfortune, disorder, disease, illness, and the social construction of illness itself, particularly illness attributed to trauma, in the hope that such a perspective will shed light on the concerns which bring us here. Last spring, I served with several of those now present as a participant in a public symposium on the recovered memory issue, sponsored by the psychology department of my university, Simon Fraser University in Canada. I observed, speaking as a discussant at the end of the symposium, how the concept of paradigm had just been deployed in reference to the present controversy. It was deployed 6 or 8 times. One of my colleagues was taking count. I used it myself, by speakers holding rather different positions on the subject, but everybody was using this term. The term paradigm, of course, is entered into common parlance through the work of the historian of science, Thomas Kuhn. It connotes a structure of knowledge, a body of scientific theory, for example, which conditions and shapes practical activities such as scientific research. One upshot of Kuhn's pervasive influence has been that knowledge is now commonly seen in sociological terms, which might be summarized as follows. This is a general summary of a kind of ambient worldview which I've constructed out of a variety of elements in the hope that it resembles reality fairly closely. If you hear people talking about the postmodern, you'll know what I mean. Knowledge is embedded in discourses, for example, those of organized professional groups, but no less in the everyday conversations of a given cultural tradition. Knowledge has no existence apart from the social groups in which it is located. And since this is so, what counts as reality is in fact a social creation. Therefore, what is to count as reality is a function of where one happens to be. There are many kinds of reality which, particularly in pluralistic societies like ours, overlap and shade into one another, depending on the social situations where knowledge claims are made, claims which are often explicitly political in nature. The making of such claims is the essence of the politics of knowledge, and the success of the claim is a function of the social power of the constituencies from which it emanates and the receptivity of those at which it is aimed. Knowledge, in short, reality, is up for grabs. Now, this summary is more radical than Thomas Kuhn's own idea would suggest, but it expresses the fact that his notion has taken on markedly relativistic connotations, such that talk about paradigms has become equivalent to talking about political allegiance. What is to count as reality thus becomes a question of values, of axiomatic assumptions which transcend mere facts and give them ontological and moral significance. Yet, there is also an ambiguous middle ground where facts and values meet square on, and I think the recovered memory debate is taking place on that very ground. Dominated as it is by academics and medical professionals who see reality as something out there, which is their job to unveil and explore. As an example, consider psychiatrist Richard Kluft, a central figure in what used to be called the International Society for the Study of Multiple Personality and Dissociation. In his foreword to a recent book on childhood trauma, Clough noted following Kuhn directly that paradigms constrain perception, that what counts as a fact depends on the theoretical presuppositions which define it as one. Certain facts fall within the pale of received knowledge while others do not, and wander about looking for a home, if they are even recognized at all. In other words, perception is theory-driven. Kuhn's point is that the myopia, as he called it, of currently prevailing psychiatric paradigms has obscured the recognition of the importance of trauma in the etiology of mental disorder. We should therefore fully explore the possibility that many patients who formerly were seen as suffering from other disorders are in fact unacknowledged trauma victims. Clough and others have applied this proposition to a reevaluation of traditional psychiatric diagnoses such as schizophrenia. For example, a number of the so-called first-rank symptoms of schizophrenia, such as intrusive thoughts experienced as ego-alien, are found in cases of multiple personality as well. Therefore, instead of being the symptoms of a severe psychosis demanding psychopharmacological management, in some cases they may be the result of crosstalk between dissociated personalities. If so, the prognosis is much more hopeful, and the case amenable to reintegrative psychotherapy without chemical assistance. Actually, this view has something to recommend it from that point of view. A therapist attuned to this new vision will have quite a different take on the facts than one still stuck in the old biomedical rut. Extend the approach over a wider variety of neurotic and even psychotic complaints, borderline personality disorder, eating disorders, and the like, and one is on the road to a major paradigm shift driven by recognition of the effects of trauma. Here Clough is still working within the parameters of what Kuhn called normal science. He correctly observes that we have a wide range of officially recognized mental disorders, though not always a clear account of their etiology, their cause. It is possible that through normative scientific procedures, Clough believes, statistical epidemiology, validity studies, and the like, greater clarity can be brought to an otherwise murky situation. Old facts looked at in new ways are the key to conceptual and therapeutic advance. Colin Ross, for example, believes that MPD is a hierarchically superior diagnosis within a large cluster of symptoms and disorders, which will eventually force a reorganization of the entire DSM system. So far, so good. At least the terrain seems familiar. In spite of the worrisome possibility that the therapeutic application of the trauma dissociation theory creates the very facts which confirm it. But there's also a question of values, not just value-neutral facts. Clough is closely allied with Dr. Judith Herman in the self-styled trauma recovery movement. Here the production of knowledge emerges not only as a quasi-political process within professional associations, but as a way of rewriting history itself, specifically the history of women, and beyond women, the history of any marginalized, abused, and terrorized segment of the population. It is therefore not just the redrawing of psychiatric nosology which is at stake here, but a wider cultural agenda, the politics of liberation. As Frederick Cruz has also pointed out, Herman believes this agenda will only prove effective if backed, quote, by a political movement powerful enough to legitimate an alliance between investigators and patients and to counteract the ordinary social processes of silencing and denial. Herman herself addressed the problem of paradigms at a conference in June 1993 on abuse and multiple personality, where she rhetorically asked, quote, who makes science, who makes knowledge, who makes theory? And observed, relative to research on trauma and dissociation, that much of our clinical research seems to come out of a dissociated space. And why? Because, quote, decision-making and power are in the hands of one sex. A science that doesn't see half the world. We need to do good therapy. We need to organize politically. We also need to change the way science is defined and the way it's practiced. Her practical proposal was to press for a new diagnostic entity in the DSM system, namely complex post-traumatic stress disorder, which will capture what she calls the protean symptomatic manifestations of prolonged repeated trauma. The political movement which Herman has in mind involves bringing about a reorientation of the American Psychiatric Association. Not an impossible dream, given the known susceptibility of that body to political pressure which led to the exclusion of homosexuality and to the inclusion of post-traumatic stress disorder, both relatively recent events. Other political events in recent psychiatric history might include the waning of the psychoanalytically tainted concept of neurosis, and in mirror image, the progressive growth in the prominence of the dissociative disorders brought about by a revisionist approach to what used to be called repression. However, complex post-traumatic stress disorder remains an outsider, nor is it cited in DSM-4 as a possible new category requiring further study. Why the APA has proven reactionary in this matter, I cannot say, though perhaps others here can. On the other hand, there has been a subtle shift in the dissociative disorders, whereby multiple personality disorder has become dissociative identity disorder, and this is particularly interesting to an anthropologist, a tentative new category, dissociative trance disorder, introduced for discussion. Part of an effort to make the DSM system more culturally sensitive. What is a name? A good deal, apparently, given the continuing debate about the status of MPD-DID. Is it a freestanding mental disorder or iatrogenically induced artifact? Here the political debate becomes vigorous. Since the same personalities involved with popularizing the idea of multiple personality disorder in the wake of the famous, though questionable, Sybil case, are also central both theoretically and clinically to the practice of recovered memory therapy. One might ask, what is to become of the concept of dissociation if the most prominent and dramatic dissociative disorder is successfully discredited? The irony is that while MPD-DID is in fact an official part of the DSM rubric, some wish to kick it back out the gate into the conceptual wilderness from which it so suddenly reemerged in the 1970s. It would be odd indeed if MPD ended up with homosexuality in the dustbin of abandoned nosological categories. Hence the puzzlement of Dr. Frank Putnam, who in commenting on these still lingering doubts observed that, quote, all psychiatric diagnostic categories are established by professional consensus. MPD and the other dissociative disorders have met all of the same requirements demanded of other psychiatric disorders. By this standard, MPD and the dissociative disorders are as real as any other psychiatric disorder, at least as real as a number of better accepted disorders. In attempts to redress the balance, counterattacks have been launched attempting to establish a neurophysiological basis for dissociative amnesia, thus pulling the issue back towards the biomedical mainstream. Meanwhile, psychiatry is confronted from the libertarian right by the likes of Dr. Thomas Zaz, who says that only mental disorders with demonstrably physical causes are the legitimate object of psychiatry as a medical discipline. So-called problems of life should be left to other discourses. Critics from what might be called the left maintain that clinicians like Dr. Judith Herman do not go far enough. That instead of proposing new diagnostic entities for the in-crowd at the APA, what is needed to prevail over evil is moral outrage and political and legal action. Likewise, there are those who hold that conceiving of the consequences of abuse and incest in medical terms at all involves power relations with medical professionals who inevitably turn victims into patients, subtly disempowering them at the same time that they purvey the illusion of survivorship, recovery, and empowerment. And so it goes. We are witnesses to the ongoing process of legitimation and delegitimation, which I have just described, and of course are deeply implicated in the process ourselves. The sociology is fascinating, and psychiatry such a messy subject, precisely because it occupies the twilight zone between fact and value, morality, politics, and science. Hence, controversies like the present one are highlighted in a way that similar debates in more arcane fields of knowledge are not. Dirty linen gets washed in public, and fundamental epistemological issues exhibited for all to see in forums like this. What then of the practical consequences of these power struggles over knowledge? The dictionary definition of a syndrome is, quote, a concurrence of several symptoms in a disease, a set of such concurrent symptoms. Proponents of false memory syndrome point to just such a cluster as typical of those who have undergone specious recovered memory therapy. Researchers such as Dr. Judith Herman advance similar packages when promoting new diagnostic entities for inclusion in the DSM. The DSM, however, has a very queerological structure. First, there is the concept of mental disorder itself, which, as the editors of DSM-4 recognize, contains serious ambiguities as to the relation between mind and body and considerable imprecision in the range of phenomena it includes. In spite of such difficulties, the current edition of the DSM has chosen to perpetuate the definition of mental disorder found in DSM-3 and 3R. Quote, in DSM-4, each of the mental disorders is conceptualized as a critical, clinically significant behavioral or psychological syndrome or pattern that occurs in an individual that is associated with present distress, e.g. a painful symptom, or disability, i.e. impairment in one or more important areas of functioning, or with a significantly increased risk of suffering, death, pain, disability, or an important loss of freedom. In addition, this syndrome or pattern must not be merely an explicable and culturally sanctioned response to a particular event. We come back to cultural sensitivity. Whatever its original cause, it must currently be considered a manifestation of a behavioral, psychological, or biological dysfunction in the individual. A mental disorder therefore pertains to A, distress or disability, in other words, to either subjective pain or objective incapacity, and B, a manifestation of a behavioral or psychological or biological dysfunction. It is no wonder that the boundaries are less than clear. Given this muddle, I find it convenient to fall back on an unambiguous operational definition that brings the social nature of the institution clearly into focus, i.e., mental disorders are what psychiatrists treat. Everything from Alzheimer's to xenophobia. What kind of disorders get included in the DSM is therefore partially dependent on the political clout of the constituency treating them. But a lack of conceptual clarity is not really what puzzles me in all this. The DSM emerged in its modern form with DSM-3 in 1980. Its then editor-in-chief, Dr. Robert Spitzer, acknowledged the substantial differences of theoretical orientation within the profession, and for the sake of internecine peace, opted for a positivistic approach to the classification of mental disorders. An approach which focused on syndromes, i.e. concurrently occurring symptoms, rather than on etiology. This, of course, is one of the reasons that the neuroses disappeared from the system, since the very idea of neurosis contained within it debatable propositions concerning causation. The result of all this is the descriptive classification that we now know. Disorder X is to be diagnosed by the co-occurrence of symptoms A and B, accompanied by at least two of the symptoms alpha, beta, and gamma. It was recognized in 1980, and it still is, that a positivistic approach has limitations, that the world of human misfortune and unhappiness is a complex one, which no simple system of categories is likely to fully capture. The multi-axial approach of the DSM was invented for this reason, as well as for epidemiological purposes. As the DSM-4 puts it, there is no assumption that each category of mental disorder is a completely discrete entity, with absolute boundaries dividing it from other mental disorders or from no mental disorder. Individuals sharing a diagnosis are likely to be heterogeneous, even in regard to defining features of the diagnosis, and that boundary cases will be difficult to diagnose. That said, all three modern editions of the DSM proceed to ignore their own advice and to develop criteria for separating by differential diagnosis the various and increasingly numerous clinical entities in the system. The disease model of mental disorder is still paramount. In other words, there are real disease-like entities out there in the world which can be identified and distinguished in the same way as it is possible to separate measles from syphilis. The therapeutic corollary is that if such entities do indeed exist, then it is also possible that we can ultimately isolate their causes and control them, the goal of all medicine. The proof in the pudding lies in the statistically based reliability and validity tests required for inclusion in the DSM scheme. They seek to establish whether a proposed new diagnostic entity will in fact be unequivocally diagnosed by working clinicians given the presence of the symptoms which are supposed to define it as a syndrome. If it can, then such an entity is worthy of inclusion in the official canon. Perhaps this process is necessary to be taken seriously as science or to satisfy insurance companies that real diseases are being treated. But to my way of thinking, it obscures matters considerably by imposing an artificial simplification on a complex world. But then, so do all cultural codes. Already? How much? Okay. Bringing matters somewhat closer to home, the process I have just outlined is crucial to legitimating the dissociative disorders. If there are precise and replicable means for separating out these disorders from other disorders, and for that matter from no disorder, then a presumption of the real-world existence of such afflictions is enhanced. A particularly important matter when it comes to multiple personality because patients with this dissociative disorder are frequently misdiagnosed, and as we have already seen, the very reality of the symptom frequently called into question. Now, I think I'm going to have to depart from the text at this point, given time constraints. But one thing that certainly emerges from all this is that there are several different kinds of classifications of mental disorders. The DSM system is descriptive, which is to say there are definite criteria of the sort I've just outlined, A, B, X, Y, Z, delta, gamma, and so forth. On the other hand, there's another way of classifying mental disorders. It would be etiological classification. We heard about something like that in the last speaker, which is to say disorders are grouped according to their presumptive cause. Now, anthropologists get at this sort of situation as well in the real-world context that I've described. And here you see a very complex process of social negotiation taking shape around deciding just exactly what is wrong with a given patient. And very frequently this pertains to not the overt features of the disorder, but to the presumptive cause of it. Like witchcraft can explain many things. It can explain virtually anything. Whether witchcraft is used as a diagnosis in some particular case pertains, among other things, to whether a person believes that others have a reason to hate him. That would then focus attention on the cause of the disorder, the ultimate cause, the witch. Likewise, in spirit possession states, such as those observed in East and Central Africa, which I have some familiarity with, both personally and through the literature, you see that again, there are syndromes that are defined very vaguely, often enough amongst women, as a matter of fact, who are particularly susceptible to spirit possession for a variety of reasons, at least in an epidemiological sense. Now, women suffering from a wide variety of causes, a wide variety of symptoms, I should say, in fact, are suffering from disorders that are just about as vague as the symptoms associated with childhood sexual abuse in our society. But there, the same symptoms lead to often very radically different diagnosis because childhood sexual abuse is not even a possibility, a conceived possibility in terms of cause. What is conceived of as a possibility for very similar symptoms to those we know here, in fact, is spirit possession as such. Then the question becomes how you get the spirit identified and exorcised. The therapeutic process focuses on these things. Firstly, deciding that it is spirit possession. Secondly, deciding who the spirit is. Thirdly, deciding what its intentions are. And fourthly, either getting rid of it or coming to terms with it. And we have to come to terms with time. So what I'm suggesting is that the process, in other words, within Western psychiatry and the known processes in non-Western societies with very different worldviews are fundamentally similar in certain basic respects. They both pertain to paradigms. The paradigms contain different elements. But even given that, the social process through which a diagnosis is arrived at is markedly similar, often extremely vague, often very political. And I think that probably should be the main point of my talk.